Good evening, Chairman, esteemed colleagues, ladies and gentlemen. Thank you for the kind invitation to be part of this exciting virtual Congress, and I'll be speaking on goniotomy for congenital glaucoma today. I have no financial interest relating to the topic. The visual prognosis of children. Good evening, Chairman, esteemed colleagues, ladies and gentlemen. Thank you for the kind invitation to be part of this exciting virtual Congress, and I'll be speaking on goniotomy for congenital glaucoma today. I have no financial interest relating to the topic. The visual prognosis in the 1940s and trabeculotomy in the 1960s, which dramatically improved the outcomes. Indeed, angle surgeries proved to be the turning point in the management of this blinding childhood condition. Angle surgery is incisional surgery performed on the drainage angle of the eye, targeting the abnormal trabecular meshwork and inner wall of the Schwann canal, reducing resistance to outflow of aqueous. There are two main techniques, namely goniotomy and trabeculotomy. While goniotomy technique has remained largely the same, there has been modifications and advancement in trabeculotomy technique over time, from the conventional ab-external method, first described with metal probes, to choices of technique now, including ab-internal approach and circumferential treatment, which will be covered later on in this symposium. Angle surgery is a preferred choice for congenital glaucoma with favorable prognostic factors. Besides very high success rates, it also carries lower risk of sight-threatening complications compared to filtration surgeries, including hypotony and a lifelong risk of bleb or device-related infections. If performed ab-internal, it also preserves the conjunctiva for future surgery, important in the long lifespan of a child. In goniotomy, the trabecular meshwork is incised under direct gonioscopic view through the cornea. There are three keys to a successful outcome, and these are adequate access, clear visibility of the angle, and anterior chamber maintenance. Access can be challenging in ophthalmic eyes, and especially in those with small or narrow palpebral apertures, such as in oriental eyes. To fit the goniotomy lens and access the peripheral cornea, we need to have lenses in different sizes, and the lateral contortomy is also helpful to increase access in some cases. Visibility may be improved by increasing corneal clarity with preoperative IOP lowering medications, hypertonic saline, as well as creation of an epithelial window by removing corneal epithelium. With regards to AC maintenance, use of a tapered knife or 25 gauge needle without any prior incisions helps. Use of a needle mounted on viscoelastic enables reformation in case the AC is lost inadvertently. Filling the AC with viscoelastic and the use of an AC maintainer are alternative ways of maintaining AC, but instilling fluid into these eyes can increase corneal haze and reduce visibility. It is also important that the assistant holding onto the eye do not place excessive pressure on or distort the eye. Maintenance of the AC post-op by ensuring watertight closure of the corneal wounds in the child is advisable to prevent AC shallowing and PAS formation, which can limit outcome. Each technique has its advantages and disadvantages. Goniotomy is my preferred procedure as it is least traumatic with the shortest operating time compared to trabeculotomy or filtration surgeries. It is precise with visualization of the angle and the incision. It is conjunctival sparing, blebless, and repeatable for greater effect. However, the view is everything in goniotomy and thus requires corneal clarity and good gonioscopic technique, including positioning of the microscope relative to the patient's head and eye. Another disadvantage is that the assistant is needed to help rotate the eye so that a greater extent of the angle can be treated. It is generally recognized that for comparable degrees of disease severity, both goniotomy and conventional trabeculotomy offer similarly high rates of success of between 70 to 90% after multiple procedures. Multiple procedures in favorable cases of primary congenital glaucoma. However, the success rates of goniotomy is much lower in most secondary glaucomas associated with ocular and/or systemic anomalies and in acquired glaucomas, with the exception of a few specific conditions with angle pathology similar to that of primary congenital glaucoma, such as glaucoma in congenital rubella, infantile sturge-Weber glaucoma, and favorable cases of glaucoma secondary to chronic childhood uveitis. Adverse prognostic factors for goniotomy and angle surgery in general include newborn glaucoma and those with later presentation over 2 years of age. Very enlarged ocular dimension, which is a measure of structural damage over time, previous intraocular surgeries, as well as positive family history indicating more severe phenotypes are also adverse prognostic factors for the success of angle surgery. I would like to talk a bit about goniotomy in glaucoma complicating chronic childhood uveitis, as this is probably the only form of acquired glaucoma that goniotomy is particularly effective for, especially in the absence of poor prognostic factors. Studies have shown that the efficacy and safety of angle surgery, including trabeculotomy and goniotomy in childhood uveitic glaucoma. The avoidance of a bleb or drainage device greatly reduced risk of long-term complications in the extended lifespan of these children, especially sight-threatening infections and eventual hypotony, as many of these eyes have aqueous hyposecretion over time. This study was published 17 years ago on goniotomy in children with chronic uveitis in Boston, Massachusetts, in the practice of Prof. Dave Walton. It's a retrospective review of 54 goniotomy in 40 eyes with uveitic glaucoma refractory to maximal medical therapy. One or more standard goniotomy was performed in these eyes with controlled uveitis at the time of surgery. Potential risk factors were analyzed against the outcomes in terms of post-op IOP and medication use. The patients in these studies were predominantly female. 3/4 have juvenile idiopathic arthritis-associated uveitis with a mean onset of uveitis at 4.5 years and mean age of surgery at 10 years. 3/4 were phakic and 1/4 were aphakic due to lens extraction for secondary cataracts, secondary or congenital cataracts. A strength of this study was that the mean follow-up duration of was very long at more than 8 years. Goniotomy was found to be effective and safe in childhood uveitic glaucoma in this study, and we believe should be considered the surgical procedure of choice in favorable eyes. However, success rate is significantly limited by older age at the time of surgery, longer duration of glaucoma, as those with successful outcome, the mean duration was 1.7 years versus 5.4 years in eyes which failed goniotomy. Aphakia. Overall success rate in phakic eye was 86%, while those in aphakic eye was 36%. Multiple previous intraocular surgeries also affect the outcome, in that those with no surgery had 87% success rate versus 0% success in those with more than 3 prior surgeries. Extensive PAS pre-op of more than 6 hours were all failures, whereas those with no PAS had success rate of 82% overall. Surgical outcome in this study appears to be unaffected by gender, onset and duration of uveitis, uveitic etiology, severity of post-op hyphema, less severe angle anomalies, steroid and glaucoma medication use. This is a video of one of my first goniotomies about 20 years ago, and my technique has essentially remained unchanged. In an ideal case, there will be a breathtaking view of the angle with a Barkan's goniotomy, such as this. In this case, I used a 25-gauge needle to enter the anterior chamber without injecting any fluid or viscoelastics. The angle is incised in between the tip of the iris insertion and the Schwabe's line. An assistant sitting opposite, holding on to the superior and inferior recti insertions with pre-placed locking forceps, rotates the eye clockwise and anti-clockwise with my instructions, so that up to 5 to 6 clock hours of the angles can be treated with a single entry. In this patient, part of the corneal epithelium has been removed, as you can see here. I think on this, it's just a small window is sufficient actually for a good view of the angle. Another eye of primary congenital glaucoma where part of the epithelium has been removed to allow a fair view of the angle. In this case, the cornea is still slightly hazy due to stromal edema, but you can see the falling back of the iris as the goniotomy cleft is created. In this ophthalmic eyes, the interior chamber is invariably deep, allowing quite a lot of space for maneuvering within the AC without losing the chamber, if one is careful not to distort the cornea or the wound. This is a goniotomy for a 9-year-old with a childhood uveitis. As you can see, unlike in primary congenital glaucoma, the angle actually looks quite crowded and narrow, but actually this is a normal anatomy of a child of a child's anterior chamber. Usually the cornea is clear in uveitic glaucoma, and with the assistant help, I can treat up to 5 to 6 clock hours of the angle. As you can see in this case. But the anterior chamber looks a lot smaller, and so actually it's easier to lose the chamber, and a meticulous technique is actually important. In those who are unfamiliar with the gonioscopy view as well as technique, perhaps pre-filling the anterior chamber with viscoelastic may help to maintain the AC. Okay, so in this video, I'm going to show a less than ideal case. This is an eye of an 11-year-old with uveitic glaucoma and shallow anterior chamber, high IOP of 48 millimeters mercury despite maximal medications. As you can see, someone has inadvertently dilated the pupil as well preoperatively, completely exposing the crystalline lens. I decided in this case to create a corneal tunnel and instill myostat to constrict the pupil and viscoelastics to deepen the AC to protect the lens. While the cornea looks grossly clear preoperatively, instilling the viscoelastic even without overfilling results in a very diffuse haze. In this case, you can still see the creation of the cleft with falling back of the iris, but my incision is slower and much more tentative due to the hazy view. The assistant is rotating the eye slowly, and I was able to treat about 5 clock hours. Fortunately, this patient did well post-operatively, and IOP fell to 10 millimeters of mercury on no medication at 1 month post-op. This is a gonio photo of a functioning goniotomy cleft many years after a successful goniotomy for primary congenital glaucoma. This patient has IOP in the low teens without any glaucoma medications. In conclusion, goniotomy has very good outcomes and have withstood the test of time as the initial procedure of choice for primary congenital glaucoma. Success depends on patient selection, extent of angle treated, avoidance of complication, as well as diligent ametropia and amblyopia treatment. Angle surgery requires meticulous attention to details, considerable skills, and experience. And the choice between the two main techniques largely depends on corneal clarity, surgeon preference, and experience. Goniotomy for congenital glaucoma should be performed by trained surgeons in centers with expertise in safe childhood anesthesia. Thank you.